about that for the next 25 minutes or so before we go into a case. And as I begin, no disclosures to report, either in the past or in the present. However, I do want to extend thank you as I do this presentation to Dr. Bill Haining at the University of Hawaii, and who sort of shared some of his personal correspondence and some of his own research with me when I was initially putting together some version of this presentation a couple of years ago for a conference. So he's a wonderful addiction medicine doc and a great mentor. And so just wanted to extend my gratitude to Dr. Haining as I do this talk. So what are we gonna do? So I'm gonna make it simple, right? I'm gonna present evidence that may support the role of cannabis as a treatment for opioid use disorder, present some evidence that might refute the role of cannabis as a treatment for opioid use disorder, and allow all of you guys, all the participants, to weigh the evidence and arrive at your own conclusion. So that's what we're gonna do. So I kept the objectives very simple. I'll start with, what is the potential role? As many of you may know, certainly in the state of New Mexico, which is where this ECHO program is based, opioid use disorder is one of the qualifying conditions for medical cannabis, right? For medical cannabis certification, opioid use disorder is one of the qualifying conditions. And that has been sort of the case, and it's been looked at in other states as well. So why, right? Like, why are we trending to cannabinoids? What is the potential role of them? So let's start with that background, right? So the rationale that's often given is that cannabis may or even maybe should be used in the management of opioid use disorder, whether in the withdrawal phase or at other points along the timeline of recovery as an alternative to existing medication. And that's something I've heard before. And part of the rationale also is that cannabis efficacy has been demonstrated in such treatment, and cannabis is safe for use in the management of substance use disorder. So those are often the claims or the rationales that have been used in a number of states that have included opioid use disorder as a qualifying condition. So I'm going to delve into all of this and allow people to gauge whether these are accurate or not, right, as we go through the presentation. But these are often the claims that are made. So what there is quite a bit of evidence and gathering and growing evidence on is the efficacy of cannabis and cannabinoids in the treatment of chronic pain. So here over the next couple of slides, I have summarized some of the big review papers that have come out in the last 5-6 years, right? Most notably, I start with the 2017 report from the National Academy of Sciences. And it's actually a really wonderful report. And if those of you who may not have read it, I encourage people to pull it up. And the National Academy of Sciences pulled together experts from around the country, scientists, clinicians, that reviewed all the evidence, all the existing evidence or the lack thereof in detail, and made a series of recommendations. And according to this 27 report, what they concluded is that there is conclusive or substantial evidence that cannabis or cannabinoids are effective in the treatment of chronic pain in adults, right? So there is more evidence. And then again, I went into some of the bigger studies. A couple of the first ones, reviews that were published back in 2015 rather. One by Whiting, one by Hill, both were published in JAMA, the Journal of American Medical Association, and both studied a number of different, both basically looked at about 28 studies, right? And Whiting said there was a moderate quality evidence, right, that treatment with cannabinoids can be helpful in adults with chronic pain, with an overall odds ratio for 30% improvement in pain, which is what we often look at in the pain literature of 1.41. Right, so about 1.5 times the likelihood that there would be 30% improvement in pain. And interestingly, smoked THC had an odds ratio of over 3. Certainly, there were also more side effects such as dizziness and sleepiness and things along those lines related to the cannabinoids, and seemed to be effective for all pain conditions. And similarly, the Hill review in JAMA in 2015 said there was high quality evidence for cannabis, for marijuana, for chronic pain and including neuropathic pain. Other studies since then, though, have not been so generous about it or have not been so enthusiastic about it. The Hauser study from 2017, which reviewed 10 systemic reviews, so it was a review of reviews, so to speak. And what they found was that the findings of cannabis were inconsistent, particularly for neuropathic pain and for painful spasms. And there was insufficient evidence for rheumatic diseases and cancer pain. Similarly, Nugent in the Annals of Internal Medicine in 2017, looking at 27 studies, said there was low strength evidence for neuropathic pain and insufficient evidence for every other pain condition. So now we're getting a little less enthusiastic, right? Then the other line of, but overall, again, if you look at the National Academy of Sciences report, looking at everything up to 2017, thought once again that there was conclusive or substantial evidence that cannabis or cannabinoids are effective in the treatment of chronic pain in adults. The other line of evidence that's often cited and used when people are talking about the use of cannabinoids in the treatment of opioid use disorder is this line of literature that shows possible reductions in the use of opioids. A well-publicized study was this study from 2016 by Bonke, which showed that when people were on medical cannabis for chronic pain, their use of opioids went down by about 64%, right? And these patients also reported improved quality of life. People also often will cite anecdotal reports where, and it's been reported in a number of studies that people say that when I use medical cannabis, I don't have to take as many opioids, right? And in Medicare, Medicaid data, it's been shown that medical cannabis laws are associated with lower rates of opioid analgesic prescribing. So in states that have medical cannabis, maybe there is less prescribing of opioids happening. So those are some of the things that were looked at. But again, the evidence there is mixed. This one study by Caputi and Humphreys from 2018 actually found that compared with people who don't take medical cannabis, people who report taking medical cannabis are more likely to report any use of opioids or sedative hypnotics or tranquilizers or stimulants, medically, non-medically, or both. There is this other study by Olson from 2018. This is an interesting study. And what these authors did is that they, there's the NESARC is one of these big epidemiological surveys that gets done in the United States. In fact, it stands for the National Epidemiologic Survey on Alcohol and Related Conditions, right? So they looked at, and it gets done periodically. So it looked at NESARC wave 1, so at one point in time, and then wave 2, which was a couple of years later. And they primarily focused in the wave 1 on individuals that reported they were smoking any cannabis. And they basically saw that people who were smoking cannabis or using cannabis at one point in time, were they more likely or less likely to be using opioids a couple of years later? Right? In fact, it was about 2 to 3 years later. And here's what they found, that compared, and this is what this is showing, that wave 1 cannabis use was actually associated with increased non-medical prescription opioid use 2 or 3 years later, with this odds ratio of almost 6, right? So quite robustly. And also with opioid use disorder about 3 years later, with quite a robust odds ratio of almost 8. If you looked at adults with pain at wave 1, cannabis use was also associated with increased non-medical opioid use, right? Almost tripled the likelihood, and with almost reaching significance of prescription opioid use disorder. So people who had pain and were using cannabis at the point 1, 3 years later, were significantly more likely to be using opioids non-medically, and were also about twice as likely to actually have an opioid use disorder. And among adults with non-medical opioid use at wave 1, if they were also using cannabis at that point, basically their opioid use worsened. So looking at this data, cannabis use actually seemed to be associated with a higher rate of non-medical opioid use and even opioid use disorder a couple of years later. Right? So again, calling into question that is this, while the population-wide kind of epidemiologic studies have shown reduced rates of opioid prescribing, to me, this begs the question that maybe it's that we're not prescribing as many opioids, but our patients are seeking out opioids anyway, right, through other means. And as we know, unfortunately, that's not all that hard to do if someone really wants to seek out opioids. So for me, again, this line of evidence isn't particularly convincing. But again, I present this data, let you guys make this. But more importantly, perhaps, is this idea that, again, these are the data that are often cited when medical cannabis has been sort of put forth as a treatment for opioid use disorder. If you think about all the data I just talked about, you might notice that none of this data actually pertains to the treatment of individuals who already have opioid use disorder, right? All of this data is around patients with chronic pain, right? What do cannabinoids do in the treatment of chronic pain? They probably are helpful. Looking at the review in some patients, although they may also have side effects. The data is looking at in patients with chronic pain. Does it lead to reduced opioid prescribing? Maybe, maybe not. But none of this data is actually looking at, do medical cannabinoids help patients who already have opioid use disorders, right? The patients that, for example, Dr. Jacobson and Dr. Maley and I are seeing at our clinic, right? So important to keep in mind that two separate populations, population with chronic pain, most of whom actually do not go on to develop opioid use disorder, versus people who already have opioid use disorder. So I would encourage you after this talk, or when you have a free time, to sort of spend some time reflecting upon that and that distinction. And also keep in mind that opioid use, which is what a lot of this data is focused on, particularly the epidemiologic data, does not equal opioid use disorder, right? For us to say someone has opioid use disorder, there has to be that compulsion, there has to be those cravings, there have to be consequences. Use does not equal use disorder. So with that, what is the evidence? So let's switch gears. So what is the actual evidence supporting the use of cannabinoids in the treatment, not just of opioid use and not just of chronic pain, but for opioid use disorder? And I've kind of done a fairly exhaustive search, right? So there is actually preclinical data emerging from animal studies. So what we find is that the mu opioid receptors, which are the opioid receptors that mediate, amongst other things, analgesia, which is pain reduction, a sense of reward or reinforcement, right? And CB1 are the cannabinoid 1 receptors, the primary receptor in your central nervous system that all cannabinoids bind to and activate. And they often are co-located in brain regions. So where there are mu opioid receptors, there are very often a lot of cannabinoid 1 receptors. And I think it's a pretty well accepted fact that cannabinoid 1 receptors interact with the mu opioid receptors and essentially modulate their rewarding properties and vice versa. So they interact with each other. Interestingly, there was this one study from about 8 years ago where they took rats and they gave little injections of cannabinoid 1 agonists, right? So things like delta-9 THC, which is found in cannabis, into the medial prefrontal cortex region of animals. And when they did that, right, afterwards, if these animals were given morphine, which normally would be rewarding, these animals did not find the morphine rewarding, right? So there is that. There are also a couple of different studies, kind of old, but what they found is that if animals were basically made to become addicted, right, or develop addiction to morphine, then the morphine was taken away, the animals went into withdrawal. And if they gave them something like THC, the opioid withdrawal symptoms went down. The opioid withdrawal symptoms were lowered. And similarly, in a more recent study from 2017, which has then been replicated to a degree in humans, importantly, they took animals who had a history of, they had basically been exposed to heroin, they had become addicted to heroin, so they would self-administer heroin, right? And then they gave them cannabidiol. They basically took the heroin away, and when they gave them a cannabidiol, those animals that were given cannabidiol were a lot less likely to go back to using heroin. So again, that's animal data. But again, preclinical data, animal studies don't always correlate with human data, right? Medical history science is rife with instances where a certain intervention, a certain treatment showed a lot of promise when it was studied in animals, right? In preclinical studies, but when they tried to convert it over to humans, it did not work out. This is, I suppose I'm kind of going back a little bit to this idea that a lot of the studies that are used to justify medical cannabis for opioid use disorders actually don't have anything to do with opioid use disorders, right? So one commonly cited study, sample citation, this is a Degenhardt study from 2015, and here in the drug and alcohol dependence, the conclusion of the authors was cannabis used for pain relief purposes appears uncommon among people living with chronic non-cancer, among people living with chronic non-cancer pain. So people who have chronic pain often will use cannabis, and users report greater pain relief in combination with opioids than when opioids are used alone, right? But again, this does not generalize to opioid use disorder treatment or management of withdrawals. This is really about patients with chronic pain. This is a more recent publication, actually from the same group. This is from, I believe this is from 2018, right? And here's what they report, that people with chronic non-cancer pain, cannabis use is common in them when they're prescribed opioids, but we found no evidence that cannabis use improved patient outcomes. So here, between 2015 and 2018, their opinion seems to have shifted a little bit towards being less enthusiastic for medical cannabis, right? People who use cannabis had greater pain and lower self-efficacy in managing pain. And there was no evidence that cannabis use reduced pain severity or interference or exerted an opioid sparing effect, right? So important to know, right, when we talk to our patients. But again, the main thing is that the main issue is pain management and not opioid use disorder, right? So both sides, pro and con, will wind up using data or evidence that has nothing to do with opioid use disorder. So now coming to, let's see, okay. So this is the Physician Guide to Cannabis-Assisted Opioid Reduction from 2017. 16 citations are given in this. It's a pretty well-known document, and a lot of physicians do rely upon it. They all allude to adjunctive management of pain, right? But none of those 16 citations actually address the utility of cannabis in the management of opioid use disorder or in the management of substance use disorders in general. And going back to Dr. Haining, and this is from my correspondence with him, he actually reviewed an additional 152 items, and actually found from the National Library of Medicine. So he kind of went down this rabbit hole. He studied 152 items to see if there was much evidence, one way or the other, that actually looked at cannabinoids for opioid use disorder. And in his words, the review was quote unquote unproductive. He was not able to find much, right? Another thing that often comes up is this reduction in opioid mortality, right? So there is this study from Backhuber from 2014 showing that states that had medical cannabis laws had 25% lower mean annual opioid overdose mortality rate compared to states without medical cannabis laws. Many of you may have heard of this citation. It was much publicized. It continues to be much cited, that states that have medical cannabis laws have about 25% less likelihood of opioid overdose mortality, right? And it's much cited. But importantly, and what many of you may not have seen, is this article from 2019, where essentially the authors of this 2019 re-examined this relationship, right, between medical cannabis laws and opioid overdose mortalities, but they carried the data forward. The original study published in 2014 had looked at data going up until about 2012, I believe. But the follow-up study used the same exact methodology. The same method was used, but they carried the data forward through 2017, right? And interestingly, what they found, was that the trend reversed, such that states with medical cannabis laws actually experience And overdose death rate that was 22.7%, higher than expected, right? So when they dragged the data forward from 2010 up to 2017, the conclusion essentially reversed. So interestingly, the investigators actually then spent a lot of time trying to explain what could be going on. And what they found was that both of these results, their own results from the 2019 paper and the results from the 2014 paper, it was false. That it had really nothing to do with medical cannabis one way or the other. That data were what they were, and their mediating relationship, other things were probably driving it up and down, and cannabis really had little, if anything, to do with either lower mortality or higher mortality, right? So I kind of also wanted to put that out. So not a lot of data, right, as is the key thing. So now this is all the data I've been able to find. We're almost at time. And, I've spent a lot of time talking about how the data is full of confounds and we don't have great data, because all the data we have is really the next 3 slides, right? So role of THC. There are actually 2 placebo-controlled randomized trials of dronabinol, which is also known as Marinol, right? It's a synthetic THC compound that found modest reduction in opioid withdrawal symptoms compared to placebo in individuals with opioid use disorder. Similarly, the Lofwall study from 2016, they took patients with opioid use disorder. If the opioids were abruptly stopped, they went into withdrawals. But when they were given dronabinol, 20 or 30 milligrams, again, the individuals saw modest suppression of opioid withdrawal compared to placebo. But they also had more adverse effects, including tachycardia, rapid heart rate, and subjective highs. The Bisaga study from 2015, it's a good study that also looked at dronabinol, compared it to placebo in individuals with opioid use disorder who were going through rapid buprenorphine detox. And they found that individuals receiving dronabinol had significantly less opioid withdrawal symptoms. And very interestingly, after these patients were started on extended release naltrexone, right, people who were intermittently using some cannabis tended to stay in treatment longer, over an 8-week period, compared to those that use no cannabis or compared to those that use regular cannabis. I don't know what that means, but certainly based on these studies, there is some data that THC can help alleviate opioid withdrawal symptoms. More recently, this Herd study from 2019 looked at the role of cannabidiol. Can cannabidiol also help reduce opioid withdrawal symptoms, right? And you can see that at high doses of cannabidiol, 200 or 400 milligrams of cannabidiol, compared to placebo, significantly reduce craving and anxiety induced by Q. So Q-related cravings and anxiety, but not overall cravings and anxiety, right? So if these people with opioid use disorder, they went into withdrawals, if they were shown pictures of things like pills or pipes, or places where they use opioids, if they had received cannabidiol, they were less likely to get cravings, less likely to get anxiety compared to those that had received placebo. So there may be something there. In terms of whether or not cannabinoids and our medications for opioid use disorders be used synergistically, the data is mixed. For injectable naltrexone, again, there are a couple of studies now that show that intermittent use of cannabis may actually increase the retention in treatment. But then other studies for other opioid use disorders treatment show a higher likelihood of dropout, right? Which is, of course, concerning because we don't want people dropping out of the treatment they're receiving. So therefore, this is sort of some takeaways for me, right? The last 2 slides. First of all, the main point I wanted to emphasize is that management of pain is not synonymous with management of addictions, OUD. I think there is a lot more evidence right now of cannabinoids in the treatment of chronic pain than there is in the treatment of opioid use disorders or addictions or substance use disorders in general. There is really no body of evidence that at least compellingly supports, for me, the use of cannabis or its components in the management of opioid use disorders. I think a lot more better quality studies need to be done. At the same time, I think this is something that comes up a lot, and I certainly agree that criminalizing use of cannabis has complicated access to study in humans and more studies, especially for the component chemicals, right? And be mindful that in the absence of adequate studies, If you prescribe or say that you're using cannabis for the management of opioid use disorder, that could be violating some of the federal guidelines. Keep in mind, and this is an important distinction, that the New Mexico medical cannabis laws talk about symptom reduction, right? Not treatment for a particular illness. So I think important to document appropriately if you do wind up doing it. And we need to continue to expand access to evidence-based treatments for opioid use disorders. So lastly, this is again my understanding of the literature. I don't think that we should be kind of saying closing the chapter on cannabinoids. We certainly need to do more research, but potentially based on the data that's there, these are the roles I see, right? During difficult initiations onto buprenorphine or naltrexone, for example. Increasingly, we're seeing people having a harder time getting started on buprenorphine, especially those that have been using high potency synthetic opioids such as fentanyl. So could something like cannabidiol, for example, or THC or medical cannabis help with those difficult initiations, right? During initiation and possibly maintenance treatment with naltrexone. As an adjunct to microdose initiations, which many of us are starting to do, where people are still having withdrawals for several days. So really during those periods of initiation where the withdrawals are still there, could these compounds help alleviate some of those withdrawals? Possibly, at least the early data seems to suggest that's possible. During taper, people who are tapering off out of their own will, could this help with the taper? That's certainly what the Bisaga study from a few years ago seemed to suggest, right? Another one is because the data for cannabidiol seems to show reductions in Q-associated cravings. I certainly have patients who say, I've been doing really well, but I know I'm gonna have cravings. I know I'm gonna be back in my old neighborhood, or my friend is visiting with whom I used to use. So during those periods of high stress, if those triggering cues are anticipated, could, for example, they use some cannabidiol during that short length of time to help get over some of those Q-associated cravings and therefore minimize chances of relapse, possibly. But ultimately, we need to carry out more research. I've included some of the, quite a bit of references that I used here for people in case they want to dig it up. Interesting topic. So I hope that was somewhat useful. I'll stop the share and turn it over to you, Rana.